Hey, it's Gonzo Gonzalez with Ask Dr. Gonzo Anything, and I'm here with my friend Cyril Varughese. Cyril, how are you?
I'm doing awesome today.
Good. Beautiful morning here in Fort Worth, Texas. For those of you listening, Cyril is one of our heart failure cardiologists here in Fort Worth, and he works with Heart Place. And Cyril, today we thought we'd talk a little bit about what happens after a person gets operated and they go to the intensive care unit, especially those patients that have multi-valve surgery or high risk. And so I thought that what we could do is you talk a bit about what the management is of those patients and how does it play out after we do open heart surgery. So go ahead, tell the listeners what is it that we typically see when we go to the intensive care unit and what the management of those patients is like.
Absolutely. So the biggest intimidating factor is you've got a person fresh out of surgery and you walk into that room and then you start seeing that there's more equipment than patient. So it starts to become intimidating and you don't really have that footing as, where do I start? What do I need to do to assess this patient, to figure out what medicines they need? How do I prevent things that can cause mortality? How do I make sure they can get out of the hospital in a timely fashion, right? Because that's what we're trying to shoot for. We're trying to make sure we hit those marks, get the patient in, taken care of, and then on the way.
So tell the listeners, what does a high-risk surgery patient look like, especially when they come out of the operating room? Because we had a couple of podcasts ago, we had Scott Ewan, and he talked about risk factors for valve surgery. But once you have the risk factors, what does a high-risk patient look like typically?
Right. So once we get past the comorbidities like CKD, chronic kidney disease, diabetic, all those things, when we start dealing with a high-risk patient for cardiovascular standpoint, we're starting to deal with a person who has multivalvular disease. So they've had more than one valve replaced. They may have underlying pulmonary hypertension from their long-standing mitral regurgitation.
Right.
They may have heart failure from long-standing aortic stenosis. And now you're not dealing with a nice normal EF. You have someone whose EF has been sitting around 30% or lower.
Right. So tell the listeners, so when you see a patient in clinic that you know you're going to have to send for high-risk valve surgery, what do they look like to you? I mean, are there certain characteristics that are much more common in those patients than in those that are not high risk?
Yeah. So really, symptoms play a really big role in terms of understanding who's high risk. So that patient who may have an EF of 30%, but they're doing a lot of their basic activities in life without any limitations. They can do, exercise almost 4 or 5 times a week. Even though their EF is at 30%, they're pretty much compensated. So we don't consider them to be high risk, even though they're having multiple valve surgery or bypass with valves. The person that we're looking at is someone who's actually struggling with their valvular disease. So the person that gets short of breath just getting up from their bed to their bathroom, and they have severe mitral regurgitation, and they have pulmonary hypertension, and they're on chronic O2 therapy at home. So we're looking at those type of factors. What I tell a lot of people is we look at a person individually, look at the person and see what they're feeling, what are their symptoms, much more so than what you see on lab work and things like that, because that gives you a better understanding of where they are in their scheme of the disease process.
Okay, so typically you're right, and so typically they show up with leg edema, they show up with pleural effusions, they have what we call end-stage complications associated to their valve disease, and they're pretty obvious. And what we typically preach when they come and see us in clinic is the fact that once they start having heart failure symptoms, classic heart failure symptoms, in the form of congestive heart failure with peripheral edema, effusions, and admissions for diagnoses like congestive heart failure, now the clock is ticking on them, right?
Exactly.
Okay.
Exactly.
All right, so moving on. So tell me a little bit about what happens post-operatively in the critical care setting.
So post-op, I'm a cardiologist, so I try to keep everything as simple as possible. And so when I assess a patient post-op, I try to look for 3 different things. One is, the most important, is the physical exam. You got to touch the patient's and see exactly what's going on with them.
You know what? Let me tell you something. You hit on something very important. Oftentimes, and so many times, people go to the intensive care unit, and the first thing that they do is they just stare at the numbers and the monitor. They don't take the time of examining the patient, and you hit it on the head. A good doctor will also examine the patient and touch the patient and make sure that they use the most common senses, or almost all of their senses, to try to diagnose what's happening to the patient. That's a great point.
Right. I mean, the way I was trained was, check your distal pulses. I mean, the first thing you've got to see, am I actually perfusing this person? So if you have someone with cold feet, automatically you know what's going on, that their cardiac output is not getting up to where they need to be. Or if they're super, super warm, they're super vasodilated, and as a result, you've got to figure out, well, are they in the early signs of sepsis? Or, and that'll help figure out a lot of things before you start getting complicated with blood work, hemodynamics, all those kinds of things.
I'll tell you a funny story. So when I was in training, there was this guy that wrote a very famous ICU book, Paul Marino.
Yeah.
And so Paul was classic when I was at the Graduate Hospital in Philadelphia. He would round. And one of the things he would do is he would feel the patient's knees. Don't ask me why, but he would feel the patient's knees. And how did he get this? I don't know. But what he would say is that cold knees, bad. Yes. Warm knees, good. So to this day, I still do the same thing. And you know what? There is a correlate, and maybe it is actually correlating to perfusion. And I don't know the entire physiology associated with cold and warm knees, but that is one of the first things that I do. I touch their knees, and that's because I trained under Paul Marino. So anyway, go ahead.
It goes back to just learning our history as physicians. People have done this for years before we even got started. We just know the details of what's going on, but they figured out how to diagnose without
right.
So I mean that's really important. And when you have someone post-op, you got to make sure their sternum is good, their respiratory mechanics are good, and the only way to do that is actually feel their ribs, see what's going on with their breathing. Listen to their heart. That's going to tell you a lot of stuff in terms of a post-valve patient, because you can get a lot of data from that before you even start ordering tests, and it can help you figure out what test you want to get. So that's the first thing I usually start off with, is assessing their physical exam, and that'll give me a ballpark in terms of what's going on with them on that day.
How much information do you gather when, say, that they arrive to the intensive care unit? And let me tell you, every time that we deal with the patient together, you're right there at the bedside, and it's almost like expecting the arrival, and you're waiting for the arrival. But how much information do you get when the surgeon walks in or the anesthesiologist walks in with the patient and they tell you about the case? What information did you try to gather about the case that will help you in terms of management of the patient moving forward?
Right. This is really important, because as physicians, we don't do this as much in terms of getting handoff from one another. I mean, nurses are great at this. They make sure as soon as their shift is done, all details gets reported over to the next person. That's why I love being in the ICU when that handoff occurs, because I can talk to the surgeon and say, hey, how much was the ischemic time? How much was the pump time? So that'll give me an idea, if I'm going to deal with acidosis, which may cause right ventricular dysfunction, so that I can kind of plan 3 steps ahead. I'll also, you get an idea from anesthesia in terms of, this is what I had to bolus them with. I had to give them a ton of epi because we started to see issues with heart rate or a response with blood pressure. So I can tell, okay, this is what they tried, this worked, didn't work. And a lot of times we get that straight hand from anesthesia, so we can kind of pinpoint our post-op care a little bit more. And we're not losing time in terms of, okay, I'm going to try this again, even though 3 hours earlier anesthesia did it and it failed horribly.
And one of the other things and you pointed out the whole thing about talking to the surgeon too, the surgeon can also explain and articulate if they had, an issue with the surgery. Although every time we go to the operating room, we hope that things are going to go your way. Listen, I've operated on patients and done an aortic valve, and that's where the dagger comes in. Every time we say, well, this is just an aortic valve. We always ask for trouble saying that statement, because something else happens, and then having to change course from that initial plan to then have to do bypasses or have to replace a root or what have you are important to articulate, because they all have at the end effect on the myocardium, which is what we're trying to protect or improve during this whole process. Okay, perfect.
Exactly. And we can only see so much with transesophageal echoes, and it's your visual interpretation that helps us figure out not only post-op care but long-term care. So if you tell us, we did a mitral valve for mitral stenosis, tons of mitral annular calcification, but also we started noticing there was some type of scarring in the left atrium. Well, in my mind, then I start thinking, okay, is this person going to be a setup for some type of atrial arrhythmias in the future? And I already have an idea where that could be coming from. There's something in there on the tissue itself, and I would not have gotten that data otherwise.
Right.
So that's an important piece of information there too, and that's why we like to stay right there as well. Plus, the anesthesiologists are monitoring pulmonary artery pressures and right-sided pressures and things like that, which also helps play into the next part, which is hemodynamics.
Okay, talk to me about hemodynamics.
And that's kind of the beast in the room, because we always have these patients who have a pulmonary artery catheter, or commonly Swan-Ganz catheter. We always see those waveforms on the screen, and it's one of those things that it's not a rotisserie chicken. You can't just set it and forget it. You've got to reassess it on a daily basis, or even several times during the day, especially if it's in that first 1 to 2 days post-op.
Mm-hmm.
So when I assess for hemodynamics, we're just kind of keeping it as simple as possible. What are the pressures in the left side of the heart? What are the pressures in the right side of the heart?
Right.
And that's how we can react to the data that we're getting.
Right.
So the first thing we always do is we look for pulmonary capillary wedge pressure. So that's kind of an indirect estimate of the left atrial pressure in that patient as well too. So the pulmonary capillary wedge pressure normally around 2 to 15, and that is done by actually inflating the balloon and measuring the actual number, so we can get a direct estimate on what's going on in the heart. Usually if that number is high, we're starting to think if someone's starting to get too hypervolemic or volume overloaded. That'll help with adjustments of diuretics. And diuretics are important because it's another one of those things that once you give it, you can't walk away. You've got to see how much came out and really want to get volume assessment there as well. So did I give my furosemide and I only got 20 cc's, or did I get a liter out? Then I can come back and reassess. Did my wedge improve? If not, I've got to get more at this as well too.
Right.
Really important in our mitral valvular patients, because they've been sitting in a high left atrial pressure. And immediately post-op, that might take a while to come down after the valve's been taken care of. So they're going to need that diuretics, and this kind of helps prevent pulmonary edema, pleural effusions, which are just setups for infections.
And you hit on the head. I think that and they taught us this also in training. The poor man's swan is the urine output.
Right.
And so as soon as we hit the intensive care unit, I agree with you. We look at the chest tube output, we look at the hemodynamics, but I always focus also on how clear the urine is and how much urine there is in the tube. Because there's forward flow, and we've basically done what we're supposed to be doing, which is basically correct the pathology that now allows all this fluid that's, instead of building up in your lungs and in the right side of your body, it's now actually getting excreted.
Exactly.
And that's one of the most gratifying parts of what we do. When you see that, you're like, oh my God,
it is.
Finally things are moving forward.
There are certain things that excite doctors, and that's urine color.
And urine output is one of the stupidest ones, but it's actually one of the most critical ones, because it lets you know about perfusion, it lets you know about their hemodynamics, and it also lets you know that what you did is working.
Exactly. So that's really important. Plus, it goes back to physiology for all the valves.
Right.
It harpens back to our pressure volume loops, our Franklin-Sterling curves. You're trying to optimize those sarcomere lengths to get as much cardiac output as you can with these patients as well, because we're dealing with these high-risk patients that are already pretty decompensated or struggling with what was going on beforehand. So wedge pressure, that's really important. And what's also important is making sure you know where your PA catheter is located. So looking at the chest x-ray, looking where your distal tip is, because you don't want it too far deep into the pulmonary arteries.
What we call wedged.
Exactly.
Because it'll give you a false reading every time.
False reading, and you're going to be inflating and deflating this balloon. You don't want to be in some distal artery that's going to then lead to decreased perfusion in that lung. You can set yourself up for infarcts as well too. So
and bleeding in it, and you've seen actually somebody, and we stopped doing that, which is probably a good practice, or we don't do it as often, but we don't wedge anymore as much as we used to because of the risk of having a pulmonary rupture or pulmonary artery rupture.
Right.
Okay.
Right. So looking at your x-rays and making sure you know where your catheter is before you start doing any kind of manipulation. Then we're set up with our pulmonary artery pressures, and this is the one that kind of varies a lot, and a lot of times this is what causes people the most angst, because we don't really know how do we react to this, because a lot of times these things have been chronic elevations in our pulmonary pressures leading up to pulmonary hypertension, right? So if your mean PA pressure is greater than or equal to 25, that's someone that we start listing as having pulmonary hypertension.
Okay.
And so a lot of times it's trying to figure out, did the pulmonary hypertension come from years of left-sided heart disease, or did they have some type of intrinsic pulmonary dysfunction as well? And you know as good as I do, you know, a lot of our patients are morbidly obese. They have undiagnosed sleep apnea, in addition to having valvular disease. So we might be fighting two distinct entities there as well. So what I look for when I deal with pulmonary artery pressures is what's going on with the vent as well too. Am I having issues with oxygenating the patient post-op? Are they on a ton of PEEP? Are they on a ton of pulmonary support and their mean pulmonary artery pressures are high? Well, then if that's the case, that's someone that needs additional therapies.
And one of the things that people don't realize also is the impact of having the patient surface from anesthetic and the hemodynamics.
Yep.
Because everybody says, oh, the pulmonary pressures are this.
Exactly.
But, you know, and you'll see the hemodynamics swing in to every side.
Yeah.
You know, they can go really high because they're waking up and they're moving. And so that gives you a false sense that, you know, they're hyperdynamic or, you know, they're hypertensive. But then the other thing happens is that they buck against the vent, and then they cause what we call a vagal response because they valsalva, and all of a sudden their blood pressure plummets.
Yep.
And then you get called by the nurse, so their blood pressure dropped. We started these drips, and when you start asking questions, well, it just coincided when the patient woke up and he started bucking the vent, and then you're like, okay, well that's actually that's just that's not going to be a big deal. So
Right. So what we're dealing with is, you know, after a long time of just looking at this patient and seeing that there's trends going up. So if we're having difficulty coming down on vent settings, repeat ABG show persistent hypoxia, that's someone that we start looking at, okay, do I need to start giving them certain agents for pulmonary hypertension? And in the acute care setting, we do have certain inhaled medications or IV medications such as prostaglandin analogs. Flolan is the one common one that we use. Inhaled nitric oxide is another agent. But all these things, what they're doing is they're just dilating the pulmonary vasculature so you can decrease some of that pressure. The big important thing is, since you're dealing with multivalvular disease, you know, you may have someone who has AS, high LVEDP, high left atrial pressure, in addition to mitral regurg that's causing pulmonary hypertension. So you may have someone who has a high wedge and high pulmonary artery pressures. If you try to vasodilate them, you're just opening up a pathway for all this left-sided pressure to cause massive pulmonary edema. So that's why it's kind of taking into fact not just one number, but their whole clinical picture.
Correct.
As well too. So that's kind of how I deal with pulmonary.
When in this whole process do you know that things are going to start? And I know that it's never 100%.
Right.
But is there a moment in the ICU care that you kind of look at the patient post arrival and that you say, okay, we're going to be fine? I know that never happens, and I shouldn't be saying that because my next case is going to have some type of problem 2 hours afterwards, and I've seen it. But commonly, what timing when you kind of sort of let your kind of relax a little bit and know that they're basically now on autopilot or cruise control? Is there a time period?
It kind of comes back to what you were saying about assessing the patient in terms of coming off sedation and things like that. So as we start weaning down sedation and I see that their pulmonary pressures are staying rock solid and I'm getting good urine output, my wedge is normal. The other marker that I was going to talk about is actually getting FIC. Fit cardiac output, which is a calculation of getting the cardiac output. Because we have a PA catheter, we can take a mixed venous gas. That becomes a huge role in terms of, are they stabilizing? So if I've got someone who's got a good cardiac output, a good wedge pressure, their pulmonary artery pressures are stabilizing, and they're coming off sedation, then I have a reassuring that, okay, this person's going to settle down hemodynamically, and we can kind of keep titrating off drips or vent support, things like that. It's usually when that sedation starts coming down in the ICU and, you know, their mean PA pressure starts cranking up into the 60s, or their wedge starts shooting up and where urine output is starting to become an issue. If I have some kind of inotrope needs that are starting to go up. So they come out of the surgery room on just epi, but now I've started to add dobutamine and vaso, and if I'm starting to add inotrope supports or increasing pressor supports, those are some times that, you know, they may not be out of the woods.
So using that example to discuss the other tests that we utilize, we have so in the ICU, to your point, we have all these monitors and tools to our disposal. But when is it in that situation that you decide to move on to a different level of care to try to figure out what's happening with the patient? When they're starting having those problems, when is it you decide that this is a time to do something different, like look at their heart with an echo or an ultrasound?
Right. So if I have someone, especially if I have someone whose hemodynamics are starting to change into something more dangerous, like if my CVP or my right atrial pressure is starting to equalize to my PA pressure and my wedge, I'm worried about tamponade.
Right.
So right away, get an echo, see what's going on with that standpoint. If I have someone whose cardiac output is starting to drop, and they came out with the mixed venous gas in the 60s,
right,
and now they're down into the 20s.
Okay.
And I'm starting to maximize my inotropic support, and I'm still not getting good forward flow. I need to see what's going on with those valves. So
Okay.
I'll get an echo with Doppler, measure my gradients across the valves, and see what's going on there. Plus, I can see what's going on with my left ventricle, but always the forgotten ventricle is that right side.
Yeah, the right side, absolutely.
And that's the one that really gets us into trouble a lot, because it's gets everybody into trouble, even with our VAD patients or ventricular assist device patients.
Right.
It's that RV that always gets forgotten and bites us in the end too. Mostly because we just don't have great data to say, okay, this is the marker that you look for RV dysfunction post-op. There are about 5 different hemodynamic assessments, and none haven't really been truly verified in terms of understanding what's going on. It's kind of just been a culmination of pulmonary artery pressures, CVP, some of these assessments, and then always that echo to see what's going on. And that kind of ties into when I have someone who's what we kind of say crashing and burning, meaning
right.
that they come out with a valve and we're still going up on inotropic support. We're not getting good physical exam data, meaning that they're blue and they're cold.
Right.
They're starting to get mottled.
That's what we call shocky.
Right, exactly. Yeah. That's that shocky patient. That beautiful crystalline urine color.
Yeah.
Horrible muddy brown color.
Yeah.
So then this is the point that's very hard to identify. Very hard for anybody, because you don't know do they need another hour of milrinone just to turn them around. But this is the point when we start thinking, especially if you're in a center that does mechanical circ support, temporary mechanical circ support, is do they need something higher just to get them through this phase? Things like ECMO, Impella assist, really to get that cardiac output, oxygenation back up to where we want it to be too.
So when is it that you then employ those types of measures?
Earlier the better.
Yeah.
That's what the data has showed, that the sooner that you can get these devices in place, the better you can preserve that myocardium and their function.
Are there times that you and I don't want to stop you talking about the ECMO piece, but are there times that you resort first to a balloon pump rather than ECMO, or do you preferentially go straight to ECMO?
Right. So it goes back to what's going on with the patient. Are they someone that really their mixed venous gas or cardiac output is mildly on the low side? They may be off all pressor support, but they're just on a small dose of inotrope support.
Right.
So I really just need to augment their cardiac output a little bit, and that's when a balloon pump can come in play to kind of help you through that phase. But if I have someone that's not oxygenating well on the vent, their cardiac output is horrible, they're starting to show signs for decreased end organ perfusion, then I know that a balloon pump is not going to get my cardiac output or my circulation, oxygenation up to where I need it to be.
Right.
That's someone that needs to we start talking about veno-arterial ECMO support to really help out with oxygenation at that time. If I've got someone, that's, again, has a low cardiac output, oxygenation is pretty well, but I just can't get their cardiac output up. We do an echo and it shows a big dilated LV.
Right.
I need something that can actually unload the LV, because
right.
now they're starting to have, VT, VF, and all these kind of rhythm issues.
Right.
That's when I think, okay, an Impella would be great in this person,
right.
because we can put it in, unload the LV,
right.
and increase our cardiac output at the same time, which will also help surgically as well, because we don't want what you just put in to get dilated
right.
and disorganized with that standpoint too.
Right.
So really it's kind of assessing the person and seeing what type of device we can implement that will actually help them out the most. So then
I guess a lot of those things happen in the short period, and hopefully we'll never get to the point that we have to do ECMO or
right.
a balloon pump. But then if they go through the first 24 hours and they're looking good, then then what's the process?
So then we start weaning support. We're still looking at these markers. So if I have someone who's got, and a pulmonary artery catheter is kind of a double-edged sword, because it's great to have to jump onto issues early on, but then it's your nemesis, because it's a foreign body that with a fresh valve, you don't want to seed anything to that. So within that first 24 hours, if I've got great hemodynamics and I'm not really adjusting any of my medications to those hemodynamics, meaning that I've got great diuresis, they're set on a good diuretic regimen, don't need wedge anymore. Their pulmonary artery pressures have been pristine, they don't need any, they're coming off of vent support, I don't need that anymore.
Right.
We can usually do a CVP, or right atrial pressure, from a central line instead of having the pulmonary artery pressure there, so we can take the swan out.
Right.
Then we still keep measuring mixed venous gases, and we can start coming down on inotropic support. Usually we try to come off of pressor support first, keep that inotropic support as long as possible, and then start weaning that down as well. But that first 24, 48 hours is kind of a give and take. So we see what the patient needs, we give it if they need it. If they don't need it, then we start coming down.
Coming back on it. Big
thing with inotropes, what I've heard a lot of people is they don't know, when do I stop, or when do I start cutting down on the dovitamine or the Milrinone and things like that. And I say, you have the access, you have the data there, you can check these fit cardiac outputs, and you can start cutting down on your support. If you start seeing that your mixed venous gas, you're starting at 58 and now it's down into 30s, hey, okay, they're going to need this Milrinone for a little longer. Let me crank it back up, let them rest, and come off of that eventually. We've had a lot of times where we've extubated the patient, get their pulmonary mechanics optimized. They're sitting up in a chair, they've got chest tubes in that are slowly coming out, they're still on Milrinone.
Yeah.
And it's one of those things that we, every day, a couple of times a day, we'll check gases. If they're good, then we start slowly coming down. Right. There's no data that says, okay, you need to cut down by 0.05 of Milrinone on 30 minutes.
This is not cookbook.
It's not. No, this is a gray area, but we have hard evidence. It's a hard science, so you have data to help you out making these decisions too. So that's kind of what we do on a daily basis. Once they start getting further away from the OR as well.
Perfect. Well, Cyril, that was really good summary about what we do in the ICU. I got to tell you, I'm sure that the listeners are probably going to enjoy and learn a lot about it. Thanks so much for being here. I know that you have a busy day today, and you took your time to come and visit with us, so thanks again.
Absolutely. Thanks for having me.
No problem. And listen, gang, thanks again for tuning in. You know that you can follow us at YouTube on the Ask Dr. Gonzo Anything channel, and on Twitter at Ask Dr. Gonzo. Again, thanks for listening, and see you in the next episode. Bye.